My name is Ruth Shim, and I am an assistant professor of psychiatry in the Department of Psychiatry and Behavioral Sciences at Morehouse School of Medicine, and I am an associate director of behavioral health for the National Center for Primary Care here at Morehouse School of Medicine. Joining me today is Dr. Monique Hunter, who is a staff psychologist for the Atlanta VA Medical Center, and she practices at the East Point Community-Based Outpatient Clinic and is adjunct faculty at the Department of Psychiatry and Behavioral Sciences at Morehouse School of Medicine. Together, we're going to be presenting on the topic of evidence-based depression care. So just a few housekeeping points to make before we start our presentation. Regarding accreditation, applications for CME credit have been filed with the American Academy of Family Physicians, and determination of credit is pending at this time. The designation will be one prescribed credit by the American Academy of Family Physicians, and physicians should only claim credit commensurate with the extent of their participation in the activity. So the purpose of this webinar is to define integrated primary care and behavioral health care, to review the evidence of treating depression in primary care settings, and to discuss clinical examples of treatment of depression in primary care. Today's presentation is going to be divided into 3 sessions with a brief intermission for questions from the audience at the end of each session. There also will be an extended question and answer session at the end of each presentation. However, you can submit questions and/or comments to our presentation throughout the entire talk. To submit a question to me or Dr. Hunter, please type in your question into the box provided and then just click the submit button, and we'll try to answer as many questions as possible. So with the logistics out of the way, we'll just go ahead and begin the presentation. So the issue here is about mental health treatment and why it should be based in primary care. And this is a key recommendation from the World Health Organization. They say that the provision of basic preventive and curative mental health care should be at the first point of contact of entry into the healthcare system. And that, in pretty much any environment over the world, is the primary care system in any country. And so the big problem that we've had over the years in the way that we practice health is that over time, mental health and primary care delivery systems have, by virtue of their histories and the patients they treat, evolved to operate quite differently. We're trying to remember that people are not kind of discarded at the neck, that you don't just treat either the top of a person or below their neck, their body, but you have to treat people in one controlled manner. So the solution is given by the Institute of Medicine in their quality improvement recommendations. And they say that healthcare for general mental and substance use problems and illnesses must be delivered with an understanding of the inherent interactions between the mind, the brain, and the rest of the body. And I think that's a great quote to go by. So then what exactly is the reason we should be providing integrated or collaborative care? There's a lot of good reasons for why we are pushing this in kind of primary care settings across the country. One of the major reasons is that half of the care for common mental disorders is delivered in the general medical setting. So primary care providers are going to be treating most of the people, half or even more of the people that have mental disorders in this country. In addition, primary care providers provide the majority of psychotropic medications for children and adults. So it's not psychiatrists that are prescribing most of the medications for behavioral health problems in this country. It's really primary care providers. However, mental disorders often go undiagnosed, untreated, or undertreated in primary care settings. So even though primary care providers are doing most of the treatment, they're not catching most of the illnesses. And when they do recognize mental illness, it's not always adequately treated in that setting. And sometimes a well-meaning primary care physician will make a referral to a specialty mental health center, and the referral is not completed and follow-up isn't done after that. So why integration is important, and we've talked about some of the reasons that it's essential, but it can be kind of brought down to three main points, which is that people with mental health problems often do not receive the treatment that they need. And when they do have mental health problems, they're more likely to be seen in the general medical care sector as they are in the specialty mental health care sector. And people are just much more likely to see a primary care physician each year than they are a mental health specialist, which means it's just more likely that they're going to come in contact with primary care providers. So it makes sense that we would be treating them in these settings. And let's talk a little bit about comorbidities, because many people with mental health problems have comorbid physical health problems, and you can't really separate out these illnesses the way we've been doing for many years in our healthcare system. So a lot of times people with major mental health problems also have cardiovascular disease, pulmonary disease, diabetes, arthritis. These are the most common of illnesses that you often see, physical health illnesses, but there's really a long list of physical health problems that are associated with mental health problems. And when you do have a mental health problem, it's more likely to exacerbate the disability that's associated with physical disorders. And patients with comorbidities usually consume the highest level of cost in the healthcare system. So that's a really important reason why we need to start addressing people as total people rather than individual singular diseases. So let's talk a little bit about what the evidence says for treating depression in primary care settings. There are three main studies that have been done that are the most, the largest studies that have been done looking at treating behavioral health problems in primary care settings. And many times, the studies that are available are on treating depression in primary care settings, so treating one singular mental health disease in these primary care settings. There have been some studies that have looked at anxiety disorders, ADHD, somatization disorders, or alcohol use disorders, but those are one or two individual studies, and there have been a multitude of studies on depression in primary care settings. So the three largest of these studies is the IMPACT, the PROSPECT, and the RESPECT-D, and we'll talk about them a little bit in greater detail. So the IMPACT study, which stands for Improving Mood, Promoting Access to Collaborative Treatment, this was a study that used a stepped care model for late life depression, and we'll talk a little bit more about stepped care in just a second. But using the stepped care model, they had a care manager who worked in the primary care setting. They also had behavioral health consultants, and they had a consulting psychiatrist. And they provided integrated brief psychotherapy and medication management within the primary care setting. And then the depression care management was based in the primary care clinic, so that was an integrated setting that was different. And what they found was a 50% reduction in baseline symptoms compared to 19% of usual care. So that was a very significant difference in improvement of symptoms of depression in the IMPACT study. And they found that 25% of people in this study had complete remission, which was compared to about 8% of usual care. So IMPACT still to this day remains one of the most significant studies looking at treating depression in primary care settings. And there's access to the IMPACT study online. It's fully replicable, and there's a lot of information about how to kind of create an impact model within your own practice. The PROSPECT study, which stands for Prevention of suicide and primary care elderly collaborative trial. This was designed to look at depression treatment in elderly patients and see if the treatment in primary care settings could actually reduce the risk of suicide in elderly patients. They also used a depression care manager who was either a nurse, a psychologist, a social worker, and that person was supervised by a geriatric psychiatrist or a psychologist. And they used a depression treatment algorithm, which is a little bit different than stepped care, but it's still following kind of a very regimented plan of action as how you're going to treat the depression. Remission was significantly more likely at 4 and 8 months for all depressed patients than usual care patients. The findings of the PROSPECT study were definitely not as robust as the findings in the IMPACT study, but it still showed a significant improvement in the treatment of depression when it was done in a primary care setting with a specific plan compared to the usual care that people got. And then there's the RESPECT-D study, which stands for Re-Engineering Systems of Primary Care Treatment of Depression. This was a study that was sponsored by the John and Catherine T. MacArthur Foundation, and it's a centrally based care management system with telephone support for patients and primary care provider feedback. So this was a very phone-based system in which patients were able to call and talk through the phone, and then there were telephone based psychiatric supervision for care managers. So care managers would call in to their psychiatrist that they were working with and go through their patient load and discuss each patient by phone. And then there was also email and telephone contact between the supervising psychiatrist and the primary care providers wherever it was indicated. Primary care providers, I think, really like this model because they can have direct contact with the psychiatrist when they have a question about a medication or they don't know how to manage a patient that's not really responding to treatment. So it ends up being a pretty popular system for primary care providers. And there was greater response rates for depression or dysthymia at 3 months. So 53% in the RESPECT-D study compared to usual care. And then at 6 months, 60% in that study compared to 47%. So let's talk a little bit about what stepped care is, because I've mentioned it a couple times now. And stepped care aims to provide the most effective but least intrusive treatment appropriate to an individual's needs. And this assumes that the course of the disorder is monitored and referral to the appropriate level of care is made depending on a person's difficulties. And so at each step, you're introducing a different intervention, a more intensive intervention at each step. So each time you move to a higher step, there's an assumption that you've already provided the interventions that happened at the previous steps. So here's an example of the stepped care model. As you can see here, at the bottom, it's step 1, the lowest. This is anybody who has a known or suspected presentation of depression. And for them, the nature of the intervention would be basic. It would be assessment, support, psychoeducation. As you move up the ladder, basically, with each step, the symptoms become more severe, and thus the intervention becomes more intensive. So you have lower intensity interventions here, and you have very high intensity interventions here. And at the top of this list, where you have severe and complex depression, risk to life, severe self-neglect, you also have hospitalization, inpatient care. So that just shows you kind of the degree to which you go through from the bottom step, which is support and psychoeducation. So with that, we're going to pause for a second, and if anybody has any questions at this point, please feel free to type them in the question and answer box, and we will try to address some of those things.
Right
and then,
now,
go ahead.
I'm sorry. I was going to address one of the questions that we've gotten so far. One of the participants is looking for ideas on how to allow for better coordination when care is not provided in an integrated system. This participant says, I'm often running into primary care docs not working with psychiatrists regarding med management, interactions of medications, and rationale for meds prescribed. So, Dr. Shim, I was wondering if you had any thoughts on possible ideas for how to allow for better coordination of care in such a situation.
This is a great question, and this is a question that we hear a lot when we talk about improving the interaction between primary care providers and behavioral health providers. And if you remember that slide at the beginning, we have, by virtue of the way that we've been set up, we've evolved to operate quite differently. And what we've had happen is a huge cultural gap that we are trying to work out in the process. So a lot of times, a big step in integrating and coordinating care is just breaking down the barriers between the primary care provider and the behavioral health provider. And the best way to do that is to start being as available as you can to a primary care doctor to help to offer your assistance to them. So a good example of that would be to kind of introduce yourself to a primary care provider that you're close to or that you know. Tell them that if they have any questions, they can always check with you, and you'd be happy to give them some advice if they had any difficult patients. Many primary care providers would really appreciate that assistance. And then, of course, if they do reach out to you at that point, then making sure that you answer them promptly and quickly makes a big difference. So part of it is just breaking down barriers by trying to bridge that divide, being more available, more approachable, and I think it takes, the onus is unfortunately sometimes on the behavioral health provider to do that rather than the primary care provider, because the primary care provider is kind of focusing on, as primary care providers do, 100 things at the same time. So they don't always have the ability to, even though they know they need mental health help in their practices, they don't always know exactly how to go about doing that. So making a connection with somebody, being available, offering your services, opening the lines of communication, I think that's one of the first steps. And then, of course, if you have more structured ways of integration, if you have within your healthcare system, if you have people that are willing to kind of move forward on integration, that definitely makes a big help as well.
I would also like to add that I know that this is not necessarily something that other sites may have as a resource, but at our clinic we provide both mental health and primary care services within the same facility, and so just the fact that there is a mental health provider down the hall, I think, makes it a lot easier to communicate back and forth. But even within this setting, we have a psychologist whose specific job is to serve as the primary care mental health integrationist psychologist. And so her role, and I'll talk a little bit more about that job title in my case presentation, but primarily that person's job is to serve as kind of the warm handoff person for any individuals who come into primary care and express a mental health need. Maybe they screen positive for depression or alcohol abuse or any number of mental health concerns, and so they can have a same day appointment, or at least within the next couple of days, with the primary care mental health integrationist psychologist. And I think that helps to decrease the likelihood of patients feeling like they're falling through the gaps. And then if patients are being picked up more consistently, I think that also helps primary care providers trust that when they make referrals to mental health, that those referrals are actually going to be followed up on and that the patients will receive services that they need. So that's a resource that is actually quite luxurious in our setting, but I think that there are aspects of that that can be kind of quilted together to provide similar kinds of services, even if you don't have the luxury of having a dedicated provider to serve that function.
Right. Yeah, it's so much easier to move towards integration when you have leadership that's committed to that. You can make some movement in this area by yourself, but in terms of kind of moving the system and moving the clinic in that direction, it really does take a commitment from leadership.
Absolutely.
It sounds like that's what you're describing, Dr. Hunter, when you talk about an integration specialist within your clinic.
Absolutely. So if there are no more questions right now, I'll go ahead and present a case that I think really highlights the role that primary care providers typically play in getting people into the door of seeking mental health services. And as I present the case, please by all means continue to type in any questions that you may have, and we'll address them at the next break. So the case that I'm presenting tonight is that of a 44-year-old African American male. He is once divorced in 1999, and now has an adult daughter. This individual is a high school graduate and has made multiple attempts to attend college, but was unable to ever complete any of his degree programs. And as I work at a VA medical facility, this individual is also a veteran, served in the United States Army from ages 18 to 22. Since his discharge from the military, he's worked several semi-skilled clerical jobs, but none for longer than 2 years. This individual presented to the VA initially through the homeless program in 2010 because he was lacking stable housing and he was seeking a shelter placement. And as a matter of course, he had to have a PPD and a chest x-ray done, so he was sent to a primary care physician enrolled in primary care at our medical facility, and presented to that appointment to have his initial evaluation done. And for all patients who are new to our system and once a year thereafter, they are screened for depression, suicidality, post-traumatic stress disorder, and substance use. And this patient screened positive for depression and had a history of one somewhat lethal suicide attempt, moderately lethal suicide attempt. And so because he screened positive for depression and also had a history of a suicide attempt, he was referred for a same-day appointment with the primary care mental health integration psychologist, which is the position that I was describing earlier. So again, that person's role is to serve as a direct contact for any patients who are coming in for primary care, but also express some mental health need. And so the primary care mental health integration psychologist then saw this individual, did a more thorough assessment of his mental health needs, and he was therefore enrolled in mental health care, was referred to see me as his ongoing psychologist, and was also referred to a psychiatrist. But in the meantime, he was seen by his primary care provider for his medical problems. He had medically he had been diagnosed with a variety of conditions, sarcoidosis, degenerative disc disease. He had a history of traumatic brain injury, migraines, hypertension. So medically he was not in the best health also. And his primary care provider at that time started him on a trial of citalopram to target his depression. But after that, he was kind of lost to follow-up. He no-showed his initial mental health appointments, and for about 3 months, he was just not presenting for his appointments. And he actually showed up again to the VA through the homeless program, stating that in the past 3 months, he had been living with family members, but was no longer able to do so, and so he was once again seeking a housing placement. And so at that time, he was again referred back to mental health, and this time he was more compliant with coming to his appointments because doing so was a condition of the transitional housing placement that he was able to secure through the VA. So although he came to his appointments, he was very reluctant to view any of his concerns as being related to mental health the way that he saw it. His depression was related to his homelessness, and that there was no other way for him to feel about his lack of stable housing, and then some other stressors that had been occurring in his life. He initially reported the onset of depression following his divorce and loss of visitation rights for his daughter, who was 9 years old at the time of his divorce. And he didn't view his reaction to these stressors as excessive, and frankly resented the implication. So we went with that, and worked very hard to use minimally stigmatizing language, talked more about his stresses and how to cope as best he could with the stresses that he had in his life. But then after several sessions, he was able to admit that he actually had a history of depression that was much more long-standing than he had initially reported, and that the depression had preceded his divorce, and that he had a childhood history of moderate behavioral problems, suspensions for fighting, and other oppositional behaviors and things like that. He had denied a history of childhood physical or sexual abuse, but did endorse a childhood history of emotional abuse perpetrated by his mother. And since his childhood, he also had displayed kind of a pattern of somewhat self-sabotaging behavior. So, for instance, after his divorce, he began having problems with anger management and interpersonal problems, and so he would frequently end up getting fired from his jobs. He began using substances, alcohol and cocaine, which he felt helped him to cope better with his anger and sadness about the losses that he had experienced in his life. And so that just kind of became a pattern of continued dysfunction over about a period of 7 years, which is when he eventually ended up losing his housing. And so one of the things that was also important in his mental health care was providing some psychoeducation between the different highlighting the difference between depression and normal sadness, and that actually while sadness and maybe some other emotions were completely normal given some of the situations that he was facing, that he did actually also have some significant depressive symptoms that were further limiting his ability to function. So through his participation in counseling, he still remained reluctant to meet with a psychiatrist, and remained somewhat mistrustful of mental health providers in general, and therefore his medications, his antidepressant regimen was continued to be managed by his primary care provider, because he would consistently no-show for his appointments with the psychiatrist to whom he was assigned. And fortunately, the clinic that I worked at was amenable to being pretty flexible with how his medications were managed. and we were able to find an arrangement that best suited his needs. And so, as I said, I think that this is a case that highlights the sometimes non-traditional roles that primary care providers may have in serving as kind of the gatekeepers to mental health care, that this is an individual who did not come to our clinic expressing any mental health needs, and fortunately we were able to do some preliminary screening and to determine that he actually did in fact have some very significant mental health needs, and hook him up with some services that hopefully continue to be beneficial to him as he works on stabilizing his life through his
Great. Thank you, Dr. Hunter, for sharing that. And I think we'll probably have some time at the end to discuss a little bit more the case and how the presentation to kind of a primary care center was so beneficial for this particular case. So I appreciate that. We're going to, if there are no questions, and I don't see any questions, then we're going to go ahead and move on and to talk a little bit about screening, diagnosis, and treatment of depression. So just some numbers, which is really important. Depression, of course, as most people know, is the leading cause of disability worldwide and the fourth leading cause of total disease burden. And there's a 16.2% lifetime prevalence within the United States, and I believe that to be a really conservative estimate. I think that there's a much higher prevalence, and people have gone up to about 25%. So the numbers range from 12% to about 25%, but I think 16 is kind of a conservative estimate. And then there's a 6.6% 12-month prevalence within the United States. And as you can see here, basically major depressive disorder and chronic diseases go hand in hand. You can't really tease them out in any sort of reasonable way. If you look at these illnesses like Parkinson's disease, cancer, diabetes, cardiovascular disease, there's high percentages of people with major depressive disorder with these diseases, and this is just a small sampling of that information. So we're going to talk now about the depression care process, and what's significant about that is because typically we kind of think about, okay, let's treat depression, that's important, but there is really kind of a four-step process to go through. I think this is really helpful for primary care providers because they sometimes like to think about things in a regimented fashion, and this is a way to give them very clear plan of what to do when treating depression. So another thing that I will say about this four-step process, step 1 being recognition and diagnosis, step 2 being patient education, step 3 being treatment, and step 4 being monitoring, is that primary care providers are often really good at step 1 and really good at initiating step 3. And I think areas where there could be a little bit of improvement could be at step 2 and then definitely at step 4. So we'll discuss all of these steps in greater detail. So step 1 is recognition and diagnosis, and I think a lot of attention is given to screening for depression, asking people about depression, focusing on depression. I think even though we're not where we need to be, even just on diagnosing depression, it is something that is at least on the radar of most people who are practicing.